Okay. Wanted to thank you all for a really good first session in this learning collective. This is an experimental format, so I appreciate your openness with the discussions. We got some good feedback on how we're putting in the introductions and formatting the discussions. We'll be integrating those today. So I'll ask everyone if they, when they're answering a question today, give us a quick 30-second introduction so we know who you are, and you remind us who you are. So I'm very appreciative of the honesty and openness in the face of difficult topics. I wasn't expecting everyone to be as open as they are. It's typically a little more difficult, so I really super appreciate that. When discussing culture and behavioral health, we can be limited by our ability to discuss and understand our own culture and cultural context. So it is, and is validated as an important part, a critical part of integrating this into practice. Opening up about our own backgrounds and how they impact practice isn't just important for our own self-edification. It provides insight and best practices for our colleagues. So I know I personally took quite a few things from the reflections and the tips that we got from you last week. And this week I'll be doing the same to try to ask questions to get you to give us some pointers as you're giving us your feedback, or as you're giving us your responses. So we will be lighter on the content and more focused on exchange. If anyone feels that they would like to dive deeper into the material or review more basic concepts, please contact me. I'm available for office hours, anything you need. After the hour-long session, I will be staying for as long as needed to continue discussions or discuss the topics. So feel free to stay in if you have the time today. No pressure, of course. So moving on to the next slide, please, Peter.
Yep. Okay.
I got. Oh wait, are we? Oh, you're doing your thing. Go ahead.
Yeah, this is just a quick reminder that everybody is muted upon entry. Please make sure that you engage in the chat. Raise your hand if you would like to unmute, and that this session is also being recorded. And then also, for those who are joining us for the first time today, the National Center for Health and Public Housing is supported by HRSA of HHS, which is a national training and technical assistance partner. And this information or content from today are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA. And also, the mission of NCHPH is to strengthen the capacity of federally funded PHPCs and other health centers grantees by providing training and a range of technical assistance.
Thank you, Fide.
Thank you.
So defining culture, can you go to the next one, please? Do you have the same slides as me, Peter?
Yeah.
22, head to 20, oh, I'm sorry. Excuse me, Amber, 23. 23. Should be the learning collaborative calendar. Yeah, okay, super. So just my disclaimers is as same as last time. This will be an immersive introduction. We will be encouraging everyone to share as much as they can or as much as they're willing to. This is a topic that is sometimes highly personal and maybe private. Sharing is not required. If you don't want to share, say pass and move on, and that is totally cool. We would like to hear anything you would like to share though. So we're going to encourage you to do that. So let's move on to the next slide, please. A quick introductions reminder, and we're going to do Halloween costumes. Again, my name is Dr. Lombardi. Please call me Kevin. I couldn't find a good costume, but I found my old Letterman's jacket from high school, so I'm just going to go wear that and walk my daughter around a cool neighborhood. So that's my Halloween. How about yours, Fide? Next slide.
Yeah, I honestly haven't bought any costumes yet, but we'll see. I'm still debating on what I should be this year. We'll see.
You're late, Fide.
As always.
Next slide, please. Okay, so we're going to go right in. We have a couple of slides to finish from last time, but just to go over cultural competence. So I just, excuse me, Fide, I'm going to go into this a little bit before you take the question. But this is a quick discussion question to get us started, and it's about, you know, the definition of cultural competence, but more importantly, how cultural competence within the workplace and within your interactions with your colleagues has a validated and important connection to your cultural competence and your ability to understand culture with your patients. Our colleagues provide an important echo chamber for our own understanding of difficult topics, and they provide perspectives. So cultural competence is important to understand culture as an SDOH because cross-cultural exchange with colleagues are key to properly understanding the concept. I know I would be pretty hampered in my understanding of it if it wasn't for my colleagues over the year expanding it, sometimes as needed and sometimes as circumstances present learning opportunities. And an important thing to remember is that someone doesn't need to be from Kandahar to be from a different culture. Even small differences in how we're raised, how we lived, and our identity can impact our cultural identity and how we see it. And as some of the reflections from our past session would show, sometimes people that we may assume have the same or similar cultural identities can have very different perspectives of our own of their cultural identity. So this is an important thing to keep in mind when we're discussing culture and cultural identity with our patients, and as we are opening ourselves to their understanding of it as it pertains to their health. Getting a grip on that is an important leveling skill, and it has key benefits to mental health and wellness. It helps us better serve our patients. Anyway, Peter, it's all yours.
Okay, so the question is,
can you read the definition first?
Yeah, so first we're going to be defining what cultural competence is. And HHS's Office of Minority Health defines it as a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations. So the question that we had for you is, first, what are specific benefits of cultural competence in the workplace? And two, how can cultural competence in the workplace improve patient care, either directly or indirectly?
And well, I'll ask you guys to be as specific as you can, and we're going to take 4 minutes and think about that, and then we'll be right back. Thank you. I've got a timer on, Fide. I'll let you know.
Okay.
All right, we're just over 2 minutes.
Okay, so I think the 4 minutes is up, Kevin, or do you want to?
We've got another one left, 11 minutes left. Let's go ahead. Let's go ahead with the fee today. I think 3 is sufficient. Do you want to go through both the questions, and I'll go through the answers? And let's do 2 people with 3 minutes each, please.
Okay. All right, so I'm going to see, would Luz Colon be available to provide the responses?
For just the first one, Luz.
No, not available. Okay. All right, what about Giselle Mejia?
Hello.
Hi, Giselle. What do you think
Hi.
about number 1? What are the specific benefits of cultural competence in the workplace, and what have you noticed in your own practice?
So specific benefits would be, I think, just the better communication. That's a benefit, because when when we understand each other's cultural backgrounds and where we come from, I think it leads to, a more respectful way of communicating. We all feel comfortable sharing. It just leads to just overall better communication and collaboration, especially because I work in a community health center. So we have doctors, nurses, medical assistants, all different, different positions. So it allows us all to be open and feel like we're in a safe environment and able to share our opinions when it's necessary.
What is the impact on patient care that can have? That's all great. I love it. But what do you think the impact on patient care is? And have you noticed anything?
Yeah, so I feel like patients can see that. They can definitely see when our communication is, if it's even there, if it exists. They are very observant, they pay attention. So even, I know earlier you were sharing about what we're doing for Halloween. Well, we have patients here that don't celebrate Halloween, there are some decorations up and they'll be like, oh, well, that's nice, but we don't celebrate that. So we also have like fall decorations in general that don't specify just Halloween or just things like that. So they're paying attention, definitely. So I feel like when they see that, I believe that also leads them to believe that we will be more open to be cultural understanding about their own, their cultural backgrounds as well.
So I agree. I've always seen this as providing a safe environment to the patients, essentially. And the environment isn't just the physical built environment, it's the social environment that they're walking into as well. So very good point. And I appreciate that tidbit. Thank you.
Thank you.
Fide, can you pick another, please?
Sure. Kayona Woods, would you like to participate?
Yes, I can participate. Hey. So for you said number 2, right?
Number 1.
Number 1.
Still number 1. So
what?
basically
Let's go for both of them. I'd like to hear what you say. They tie together so well. I'd like to hear what you have to say to both of them.
Yeah, because I was going to say, I basically said about the same thing, because like the specific benefits of cultural competence in the workplace is giving you a deeper understanding of coworkers as well as clients, for being able to better relate with those you work with and those you work with like on a professional stance, and like being more relatable. Knowing about somebody's maybe cultural background could help you on how you need to address an issue with them. And then also just basically for number 2, understanding someone's cultural background will help with assisting them in many different ways. Knowing where someone's come from, for knowing how to approach a subject. Like I work in housing, so certain things, and especially working with more lower income individuals, or certain ways to approach how to talk about certain things, or like when you run into hoarders and things like that. There's certain ways that you talk about the situation and without offending people, that sort of thing, because hoarding is technically a mental disability. So you have to be careful about how you handle certain situations and certain things. So having that cultural competence will help with that.
So in your practice and at your center, have you noticed any benefits of cultural competence and understanding between colleagues on patient care? And if you haven't, that's fine, but I'd love to hear if you have.
I think so. I think for the most part, for my office, it's a smaller office, but most of us are pretty good, especially when it comes to like our senior citizens. So like right now, for example, our wait list is opening up on November 1st, and everyone's pushing for doing everything online. Applications have to be filled out online. We're not accepting paper applications, that sort of thing. Well, with some of our older people, they don't know how to utilize the computer properly and that sort of thing. So then we grant exceptions and we know how to talk to them. We just tell them, make an appointment with us, come in, and we'll help you with that. So like, because some people don't think about it, that is another culture too.
Absolutely. I know that my grandmother's never turned a computer on in her life, and she has no intention of doing it. So that is a barrier 100% for care. Thank you. Can we move to the next slide, please? It's the answers. Peter, thank you. So here's what the data says. So better communication and understanding amongst colleagues is absolutely important. And lower likelihood of interpersonal conflict stemming from cultural misunderstandings is absolutely important. But you really don't understand, it's hard to really feel that until you've worked in a workplace that does not have a high degree of cultural competence, and you can see how it both affects you and how it affects your patient. So my understanding of it and the understanding of the data that I've read is like, one, it's important for shaping the interpersonal environment of your facility. Fewer interpersonal conflicts, more cultural understanding is something that patients can feel when they go into a clinic, when they go into a clinic room, because it shapes our interactions with each other. This is particularly true of those who come from backgrounds where they don't always feel included culturally in institutions in this country. So self-realization, exposure to cultural diversity leads to better understanding. Exposure to culturally diverse staff can lead to more inclusive and more open organizational structures, and culturally diverse organizations have access to more diverse perspectives. I think we've all been in a circumstance before where the background of a colleague has given us insight into patient care. Next slide, please. So for question 2, better appreciation of race, ethnicity, and culture leads to more effective patient care. More culturally competent organizational structures impact patient treatment experience as well, because if you understand your community's cultural context better, creating structures that accommodate the folks in your community is much easier. And outward appearance of cultural competency can increase trust amongst the community, agency, and staff. And I can't emphasize how important that is. And I'm sure all of you have noticed that in your own practice, that having a facility that appears, that gives the appearance of being culturally competent, certainly allows patients to be able to access behavioral health in a more fluid manner. Next, please. Okay, so this is our sections for today, the impact of culture on mental health. And what I'm going to be doing is presenting a case to you, and we're going to be answering some questions about the case, going through the care that the patient got through the case, and trying to get some takeaways on how we can be more culturally competent in our own practice, and also how we can critically pull apart some of the structures that are imposed on us as healthcare providers. So the case study. So I'm going to read it. You are a behavioral health worker for a health center with an attached urgent care center. You were working in the urgent care center. You have a 42-year-old person who presents to the emergency department for chest pain and difficulty breathing. The patient information defines him as male and Caucasian. You know nothing else before you go into the room. The patient has already undergone a physical examination, and labs diagnostics have been collected and analyzed. Clinical findings were largely unremarkable, and the patient has been cleared medically by his attending physician. You are assigned to the care team because there are concerns that the patient may be experiencing a behavioral health emergency and requires assessment and potential linkage to care. Upon your examination of the patient, you notice that he speaks English, and he has an accent you don't recognize. You're given a surname, and he appears agitated and excited. You have no concerns for your own safety, and you continue your assessment. Next slide, please. Can we get hands if anyone knows how to read EKGs or is into EKGs? What's the most common finding in a patient who's having an anxiety attack or is a post-traumatic stress disorder patient? Can anyone tell me what the EKG finding is? Sinus tachycardia is what you'll find almost all the time. So just to go briefly over, I know that you folks, some of you folks may not look at vitals and so forth in your clinical practice, but it is important. So I just want to briefly go through it. The notes from the medical record show this EKG. It's read as normal as sinus tachycardia. The bedside ultrasound showed normal cardiac motion. Physical exam notes that the patient has normal free reflexes, but a bounding pulse and tachypnea, deep breaths. Vitals are 80 beats per minute, 22 breaths per minute, which are both elevated. The blood pressure is elevated at 210/110 as well. So that's at the level of hypertensive urgency. Lab results are significant for elevated cholesterol, but there's no other abnormalities as cardiac enzymes are normal and within normal range. Drug and alcohol screens are normal. When asked to define his cultural identity, patient notes he's from Armenia and he has lived in the States for 5 years. Next slide, please. Okay, so this is our group of questions that I'd like to take 10 minutes to go through and then discuss. I'll ask all of you to be as detailed as you can. Going over the case will be the majority of the session today and the reflections we take from our responses. So just to hand it off to Fide, and she will read the questions.
Okay, so for the first question we have, well, the patient will require behavioral health follow-up. And the first question is, as a behavioral health professional, what are your main responsibilities in this circumstance? And the second question says, how would you ask the patient what their cultural identity is? How would this information impact your approach? For the third question, how might the patient's cultural identity be influencing his decision not to access behavioral health? And for the fourth question, if you have no formal knowledge of the patient's culture or cultural identity, what can you do with this information? Also, what does this case tell us about the limits of using race alone to define patient identity? And 6, how would you encourage the patient to access behavioral health?
So this is a long one, and I'm going to ask that you guys be as detailed as you reasonably can in the 8 to 10 minutes. So I'm going to set a timer for 8 minutes, and then we will reassess and get our responses. But I don't appreciate is if you can throw in some clinical vignettes from your own experience, if they're relevant to the question, please do. Thank you. All right, Fide, the timer's on.
Okay. Kevin?
Yes, ma'am.
Is it possible to put the questions in the chat?
Oh yeah, sure. Let me find them on my slide. Yeah, I'll put them in right now. I found them.
Thank you, Jill. We're working on that right now.
There it is. Thank you.
Okay. Has it been 10 minutes yet, Kevin? Yes, right? I believe so. Okay, so for the first question, I'm gonna ask for a volunteer. And whenever you provide your response, if you can also give a brief 30-second introduction of yourself and what organization you're joining us from. Please, do we have a volunteer for the first question? Okay. Be shy. You don't have to provide the whole answer. Just any thoughts? Mhm.
Can you hear me there?
Has anybody volunteered?
Yeah. No, not yet. Not yet. You can go ahead and provide your response.
I'm a little intimidated by the main responsibility, but I can just tell you what came to me. Basically, I thought that it would be really important to understand what triggered his response, his panic attack, just to understand the conditions. I'd want to know if there are family members available to talk to, and has it happened before, and how did he cope? I don't know. But that might not be the main responsibilities, but that's just thoughts I had on the
On the first question. Okay.
yeah, on the first question.
Okay. And where are you joining us from, Jill?
Oh, sorry. So yeah, I'm at Charles River Community Health Center in Boston.
Thank you.
So absolutely, Jill. Thank you for that. And by the way, these are purposely vague to capture the diversity of response here and the different clinical environments in which we all work. So please just shoot. As someone who's trained in the ER, I gave something that may be very specific, but it nonetheless shows us an important perspective of what our responsibilities are. And in this case, why did they send you into the room? Is this patient needs follow-up? So that's the primary output. In your assessment, though, 100%. Understanding those are foundational to being able to link them to care and are intricately connected to it. So yes, 100%, and thank you. Do we have another response? If no volunteers, we can go to the next one. That one's a little, there's not much more we can get out of it, Fide.
Okay. So to the next question, how would you ask the patient what their cultural identity is? And how would this information impact their approach? All right, do we have anyone who would like to respond? Herman Vargas, would you be willing to provide any thoughts on that question?
Yeah, sure. Well,
Thank you.
I've been having some issues with my audio on my computer, so I'm using my phone. I hope you
We can hear you fine.
Okay, great. My name is Herman Vargas. I do work for Intech Community Health Centers in Texas, in Arlington. So going to the question, are we in question number 2, right? Or we are still?
Yes, sir. Number 2.
Number 2, okay. I will say we can always assess in the cultural identity, just be clear. I mean, what is, if there's, for example, what I will do is, first of all, I will assess for our body language, our distance between one another. How do we approach? I mean, there are some cultures that definitely have a for example, tone of voice a little bit higher than others. Distance between how close can I approach to my client? If it's a client that you may not be able to allow me to approach too close, definitely I will consider that. How far I am from the client. Definitely eye contact as well. That will be for me. I will, if it's a male or female, if it's a female patient, definitely my approach, it will be definitely I need to consider that. The stigma also, I will try to assess assess into just as a regular assessment, like how do you get here, or if the person is with someone else there, if there's something that is probably triggering what's going on right now. I will ask questions, but definitely I will consider that, like my body language, definitely, and also I will be alert with body language of my patient as well, and tone of voice, and yeah, I think that's something that I will take into consideration.
Thank you, Herman. This is cultural identities is we're presenting it as an SDOH, and when it's considered that way, I like to think of it as a data point in your assessment. And as clinicians, when we're going into an environment and we don't always know what we're walking into, what are we doing? We're assessing data points, sometimes very quickly, and we need to be on our feet to analyze the needs of the patients and so forth. Culture is one of those data points that's very important to your care of the patient, particularly in behavioral health, because of the complexity of the work that we do. When I'm in this circumstance, whenever I was interviewing a patient, whether it was behavioral health related or not, I would ask them flat out, how do you define your cultural identity? And I get confused response sometimes. Most of the time I got very good responses from patients, and they'd be accommodating if I didn't understand their cultural context, and they'd be happy to share. What does this present? But it presents an opportunity to connect with the patient and show understanding without really even doing anything. Just the asking of what someone's cultural identity is in that way. How do you define your cultural identity is inclusive, and it communicates something about you as a provider and about the institution that you work with. So I'd encourage you to articulate it in a way that's open and accessible. How do you define your cultural environment is how I did it. How the information affects your approach is going to depend on what the information is, of course, but you should go into it with an understanding that this patient's cultural context and cultural background may have an effect on what I'm going to do with this patient. For example, if there's a patient who has a cultural background that you don't understand or you don't know, when a patient tells you what their cultural identity, the next question to follow up is plain and simple. Is there a way I should integrate that into our practice? Or is there a way that your cultural identity should be integrated into your care? Asking in that way. The reality, though, is a lot of times the impact that knowledge of one's culture is going to have on your approach to the patient and your clinical care is not as clear. The patient won't always be able to tell you, well, actually, I'm from Rwanda and I'm experiencing some because of this and this in my past. At that point, the onus is on you as a clinician to have that understanding or to ask questions. And the knowledge of your community and knowledge of the cultures that are represented in your community is the most important asset to be able to do that. So we can go into, thank you, Herman, and if we can go on to question 3, please.
Okay, so question 3, how might the patient's cultural identity be influencing his decision not to access behavioral health? See, I'm gonna pick on someone. Joshua Nye.
Hi.
Hi, Joshua. How are you?
Good.
Good.
So, am I answering all the questions? Yes.
Just number 3.
Number 3, please. And if you could give us a reminder, I know you gave an introduction last time.
I'm having a hard time hearing you. Say that again.
If you could just give us a quick reintroduction and then answer the question, please, Joshua. Thank you.
Weird introduction. Hold on.
If I remember correctly, you did give us an introduction last time. To just refresh our memory, please.
Yes. So I'm the. Are you talking about introducing myself?
Yeah, just a brief introduction of yourself.
Sorry. So I'm a little slow on the uptake. So I'm Joshua Knight. I'm the clinical director for Charles River Community Health, and I share a background of Swedish and Lebanese. So there you go. There's a good mix. And in terms of question 3, I wrote them down because I actually got called off to the floor. So I wanted to pull this up real quick. Question 3, how might the patient's cultural identity be influencing his decision to not access behavior? So I wrote down very quickly on this one, cultural stigma. So stigma about mental health spans across, in my opinion, a lot of different cultures, including my own. So I kind of had the knee-jerk reaction of stigma alone is affecting this individual, can affect this individual's ability to access services appropriately or want to access services appropriately. So that was my response to this.
So you bring up an interesting point. First, I have a follow-up for you, Joshua. You mentioned that in your cultural background, that can be a barrier. Could you describe that in a little more detail, plees? And you mentioned cultural, so which one of those is it?
So actually in the Lebanese culture, you know, a lot of the older generation, my parents and grandparents, they would consider mental health, you know, a weakness. And there have been situations in my own family where individuals have experienced or had mental health and they were dismissed from the family. So I'm actually the first person in my family to be in mental health. It's much easier for my generation, I think, to do this. I also come from a much more adaptive and progressive Lebanese family than most. But
LC Louise, please dial 7431. LC Louise, please dial 7431. Thank you.
Sorry about that, guys. So, so yeah, that's where I was coming from on this, and that was the quick response that I gave, because I feel like I believe when you said this individual was Armenian.
Mm-hmm.
Yes. So, you know, the first thing I think of, you know, is my own culture when it comes to that, and you know, whether or not this individual wants to cross that barrier. So yeah, there you go.
Thank you for that, Joshua. I appreciate the personal tidbit on that. It must have been an interesting career going from a cultural context like that to someone who's a leader in behavioral health. So I commend you for grabbing that bull by the horns pretty effectively in your own life.
Well, thank you. My family's very accepting of it, but I will say the community that I'm from, you know, not so much. So yeah, it's a very interesting piece.
We struggle with that in my own culture as well, so I can relate to you and I appreciate the openness with that. Something comes to mind that's important when discussing taboo. If I were to spend the day, I could spend the day listing the regions of the world where Western behavioral health is taboo. It's very common. Throughout the world, there are indigenous and local ways of integrating behavioral health that are different than the way that we do, and sometimes adapting to that cultural context in the United States is incredibly difficult. I found that that's particularly true of parts of the world where the populations have dealt with historical trauma, and when it's population-wide, at times there can be a disincentive to share feelings relating to that trauma because it's seen as a burden, or that everyone else isn't experiencing the same thing. And that can be complex. But the taboo is 100% what we're dealing here with this patient. And there are large Armenian American populations in Massachusetts, very large ones, Boston, Waltham, and throughout like the North Shore suburbs, there's very large communities. There's large communities in Los Angeles as well. And this is a population that's experienced just that, historical trauma, quite a bit of it, hundreds of years of genocide and complex geopolitical situations have created a population that has experienced a disproportionate amount of trauma. And what does that do? At times it can shape the perspective of behavioral health and the perspective of accessing behavioral health. So having an understanding of that is important. But I mean, the question often comes to, okay, you understand this is a taboo, how does that help? And it's not like this is a, you know, this patient is having a cardiac issue and I give them a medication to fix the issue. Taboo is multi-generational, it's complex, and it takes a long time to manage. It's not something that you're going to fix in a exam visit. If you do, please send me an email and I'd love to know what you did. But these are things that can take generations to dismantle, and it can take generations and years to get individuals to want to access behavioral health. And when I was in clinical situations where I was frustrated because I felt like a patient's cultural identity or perspective of behavioral health was a barrier to access, I often asked myself how I would deal with that situation, how I would feel in that situation. But the reality is, to build trust in the system, it takes a lot of positive clinical interactions. Every time you have a clinical interaction with a patient, in general, that's positive, you are improving their perspective of behavioral health. And it's particularly true for those from other parts of the world that may not have a lot of experience with behavioral health in the United States. And the way I like to think of it is supporting your colleagues and setting up the next provider for success. Strategies include demystifying the process, explaining how the process of getting behavioral treatment is, and in a way that the patient can understand. And often defining behavioral health issues within the context of the patient's non-behavioral health clinical condition can be extremely helpful. This is a patient that is experiencing GAD and PTSD and as a result has very real clinical symptoms that has brought him into the ER. Now, I've found in my practice that if a patient is there for something like that, and they also need behavioral health treatment, passing them off to a provider in the outpatient setting, a primary care provider, or so forth, that can treat both of those issues is extremely important, because the follow-up will include both of those. But also, when a behavioral health and a non-behavioral health condition are both tied to the same symptoms, at times it can be helpful to use those symptoms to encourage the patient to get the treatment. And plain and simple, if you can articulate to the patient that his behavioral health concern in this context is impacting his non-behavioral health as well, at times it can encourage the patient to go forward and access that care. But sometimes it can take a long time. And our responsibilities to each other is to support the system and to support each other by giving patients those positive interactions so that that trust can hopefully build. I will say that one bad interaction will do a lot more damage than many good interactions. And having just one interaction where a patient doesn't feel like he is safe or she is safe or they are safe can bring that process back significantly. So in many ways, we are ambassadors for this system, and that's an incredibly important part of what we do. Thank you, Joshua, I appreciate that. And if anything, your career certainly shows us a little bit of that. Fide, if you don't mind, please. Thank you.
So we have a hand raised by Jill.
Yeah, thank you. I guess I was wondering in that situation if you can, can you just name the possibility that, you know, I've had other patients in the past tell me that, you know, once you've asked their cultural identity, that, you know, blah, blah culture might need other family members to be involved in this discussion before, you know, is there someone in your family I should call right now to explain, or or something like naming it, like naming the hesitancy in terms of a cultural norm, if you can, you know, and then asking for, you know, is there any way we can work with that? I don't know, just like putting it out there.
That's a good question. I've struggled with that for years, Jill. I appreciate you mentioning it. And it's just so I understand you appropriately. You're saying, plain and simple, I just want to ask. And is there an issue with asking? And my answer for that means it depends. And because nothing's simple in behavioral health, right? You know, so, and what the answers are really, it comes to your understanding of the cultural context, your membership in any of the groups that the patient might be in, and really just the body language and your assessment of the patient. And I'll go through why that's important. One, sometimes asking, and it depends on how you ask, of course, right? And the way I always suggest is just asking, is there any ways that that your cultural environment should be integrated into your care? Is just a good way to start. Sometimes patients won't understand, and asking like, is there a relative or someone that I should call is a really good way of kind of asking the same question.
Yeah.
Which is very important, and I appreciate you mentioning that. But plain and simple saying, hey, notice that you said you were Armenian. Is there any like thing I should know about behavioral health in your culture? That's a good thing to ask. But where I draw the line is if you're making any assumptions to categories or groups that the patient belongs in, I would urge some trepidation. If the patient is identifying the cultural group and offering that information when you ask them if it's relevant to their care, I think you're within your bounds to respectfully ask how that can be integrated. 100%. Did that answer your question, Jill?
Yeah, it did. Yes, thank you.
Thank you. I mean, this can be hard, especially if there have been clinical environments I've been in when I've walked into a room, asked someone what their cultural environment was, and I could not point on a map and tell you where that place was that they came from. And that can be hard because you're essentially exposing yourself to the patient saying, I just don't know. And it's hard for us to say we don't know at times in clinical situations where we are trying to show the patient, we're trying to exude confidence and competence. In this situation, asking does exude confidence and competence, in my opinion. What my finding has been is when you have patients, especially who are newcomers to this country and or your region, asking that question is important to them, or can be very important to them, and can act as an ambassador to care as well. So I'd encourage you to do it every time. Even if you don't, when you look at a patient, you may assume that they don't have those difficulties. You'd be surprised how many people act and talk like Americans who may come from cultural environments where that it's difficult to do that. At times people are very good at code switching, and you wouldn't be able to tell what the barriers are at home. So ask. Thank you. Fide, if there are no hands, the next one, please.
Okay, just a reminder that we are actually right at 2 o'clock almost, Kevin.
Okay, let's go with this question, and then I'll take it and invite folks to jump off if they need to.
Okay, question number 5. What does this case tell us about the limits of using race alone to define patient identity?
This is a good one. I'd really love to hear a response from someone on this. Does anyone have a hand and how they would approach this question? Sorry, Fide, I'm grabbing here. I'm just excited.
No, that's fine. It's an interesting topic. I am interested about listening about this.
Can I jump in? Because I do have to go at 2. So I figured I'd share and then sign off. So I took this question as if you're only going from a single entity, you only know that entity of that person. And a person is made up of several different pieces rather than just race. So when you just go in assuming the race alone, or only addressing the race alone, you're only addressing one fragment of the person. So that's how I answered it. Hope I wasn't off target.
Love it. That's perfect. 100%. So we have cultural ways of defining identity in the United States that are, thank you, Joshua, so much. We have cultural ways of defining identity that are, let's be honest, attached to structures that don't have the greatest history. These are structures that at times have defined communities in a way to commit violence against them or to marginalize them. So defining someone just based on the category is limiting, and it's also potentially could ostracize the patient in some way. We had some discussions last week on cultural identity and how folks define their cultural identity. And a couple of our volunteers actually said, this is how I define my cultural identity. It's different how I would have assumed they would. So this is incredibly important stuff. Race also doesn't tell us much. I know that my daughter's half Haitian, and when she's in the United States, she's described as Black, but if she goes over to Haiti, they call her white, just because of how the races are defined differently in different societies. So depending on who happens to be writing the medical record and who happens to be writing the first note, you might see a cultural identity there, and the only way that that person screened it was by looking at the person who's in front of them. In general, when you are reading a medical record, if it says what the patient's race is, it's garbage information, because usually people do not engage in proper assessments. The impetus is on you to properly assess that. And if it just says race, that should raise a red flag. Now, the reason race is typically put in medical records is, a reason that physicians say they do it is because there are treatment differences you would do for different race. They would say connect papers are on certain cardiac drugs or so forth. I think the data on that is garbage, and that imposing a cultural identity on a patient is a form of violence every time. If the patient defines their cultural identity, put it in the medical record. If they don't, please do not, because it is an imposition of identity. The feedback I've gotten, and this isn't something I found out by myself, patients told me to stop doing it. And one of the best points of feedback I got from someone who was multi-ethnic, multiracial, who I defined as African-American, was that their identity was complex. And when they keep getting when they have documentation that consistently defines them in a way different than they define themselves, it's in a way an imposition of identity that can affect them psychologically. So just by allowing the patient to define their own culture on their own terms, that has a therapeutic benefit immediately, which is incredibly important. So I'd encourage you all to allow them to do that. And when you're putting it into the medical records, if you write medical records, please put it how the patient defines it. That's important not only for the patient, but also for colleagues to see that we are doing things like that. Let's be honest, we're in a crisis of how we define race and ethnicity within medical context in this country. And leadership is often by doing in this. And what I've found is when I've worked with colleagues that don't approach this in a progressive way, that doing it in my own practice at times spreads. So I'd encourage you to do that. It is 2 or 3. If anyone wants to jump off, fine. But I'll be going on to we'll be passing these questions and going to a couple more things that might be interesting. I'll also be staying if anyone wants to chit chat or share clinical vignettes or so forth. I do understand that you guys are busy and so forth. So if you got something to go for and do, please do it. Appreciate your time, and I'm looking forward to your participation next week. So transitioning. So how would you encourage this patient to assess behavioral health? And a lot of this is not really an answerable question, because it's not, tell them, there's no quick answer to this. And these questions were meant to elicit this. And the answer is based on your assessment. My recommendation in an ER setting or in an urgent care setting is to always integrate primary healthcare into it as much as possible. So of course, always remember that. But depending on the patient, how they define their cultural context and what they say, you may find that different resources are more helpful for them. So my recommendation is, 1, know all of the resources in your area. If there are culturally specific resources, even things like faith groups, cultural associations, or so forth, refer the patients to that. but also keep in mind that the answers to this are going to be different each time. Next slide, please.
Okay.
Okay. So how does cultural stigma impact mental health? So I can't emphasize enough how common stigma in behavioral health is. And I'm certainly not the only one who's noticed this. Behavioral health itself is culturally mediated and defined. It's very difficult to find an objective measure in behavioral health that can be applied cross-culturally. And that's the bottom line. And the reality is there are behavioral health correlate systems that exist throughout the world. They may not be defined as behavioral health, but clinically they have a behavioral health impact. This can range from faith groups to traditional healers to, in some case, to various other systems as well. But having the understanding that just because a patient is seeing something as taboo does not mean that they don't have local or indigenous systems that they utilize to assess and to treat their behavioral health. And a way that this can be assessed is by just asking. If a patient is diagnosed with depression, one of the first things I always ask is, how have you been managing your symptoms? And delving into the systems that a patient accesses, be their home or indigenous systems, is important to understanding what the therapeutic approach should be. Next slide, please. Okay, so like a case study, this was an Armenian American individual. There are large Armenian American populations throughout the United States, but primarily on the East Coast and the West Coast, New York City, Boston area, and Los Angeles with some of the largest communities. But it's a very large immigrant population that's been here for several generations in some cases. If you have knowledge, so Armenia is in between in the Caucasus Mountains, and it's a population that has experienced a cultural genocide for a number of centuries. And in my experience, working with this community in behavioral health can be a challenge because behavioral health is not something that's traditionally used in our sense in their culture. There's also a significant taboo. And as I mentioned earlier, my finding has been in places or in cultures and in communities where historical trauma has been persistent and consistent, at times that taboo is there and it's very common. And my inclination from speaking to individuals and from reading the literature is that that has a lot to do with the fact that in some cases, when there is historical trauma, the whole community is experiencing it. So it can be difficult to stand up and say you need help for something that you believe everyone else is experiencing. So my recommendation is ask. Ask about cultural identity. Ask patients what systems they use when they have what systems they use for their symptoms, and have an understanding of that. There's a body of knowledge that comes over the years with engaging with patients from different cultural backgrounds. Especially if you're working in the same area, you might find that over 5 or 10 years, you become very, very intimately aware of the cultures in your area. Interacting with patients and asking them questions, in addition to helping them integrate into the behavioral health system, also helps you as a provider understand the folks that you're dealing with, and understanding that, like, let's be real, there's not a culture in the world that's monolithic in any sense or in any dynamic. So within the communities in your community, there is there is diversity that you'll understand as you work more with patients. And there's intersection between different types of identities that you might learn to understand that, say, a female or a male from a certain culture may see something different, or so forth. Next slide, please. And one after that, we're gonna speed it up. Okay, So this is a case study on Haiti and Haitian Americans. There are large Haitian American communities throughout the East Coast, from Miami up to the Boston area. There are approximately 2 million in the United States out of a global population of about 10 million. So it's a very significant community. And this is a community that at times members can be resistant to the behavioral health system. When I was in medical school and early on in my practice, I was the executive director of an organization that ran a behavioral health program in Léogâne, Haiti, which was the epicenter of the earthquake. Now, my finding and what I was told by my mentor, Dr. Tony, who's in the picture on the left, is that the behavioral health environment in Haiti was intensely complex. And there was a couple of reasons. One, there was an earthquake in 2010 that it led to about 400,000 deaths in the country. Out of a population of about 8 million, that means that almost everyone you're going to meet has had multiple people in their family that died in a very tragic accident. So that's the definition of collective trauma right now. And what I found in my practice was that cardiac issues were exceptionally common and that they were masking behavioral health issues. But it was very difficult to encourage patients to engage in behavioral health at all in the clinic when I was there. Also, there were no available systems. We couldn't send them to a therapist in Port-au-Prince. It didn't exist. And what we did was, frankly, we asked the community. And that's why I'll encourage all of you to ask about the systems and the ways that your patients engage in behavioral health within their own cultures, because in Haiti, there's a very strong local behavioral health tradition, and it's local alternative medicine. When I spent with alternative medicine practitioners in Haiti, I noticed that a lot of what they were doing was plain and simple just therapy. And it was therapy mixed with alternative medicine, but it was very heavily focused on therapy and conversation. We made a decision to integrate voodoo medicine into our primary care center in Léogâne, and it was the only way we could get people to assess behavioral health, and we had very good feedback from the community regarding that. Often, they would come to our clinic to see the traditional healer instead of the medical healer. And that would give us an opportunity to also get them to see the traditional hero, the medical healer. And that brought me to a conclusion that I think is important to realize in our practice here in the United States, is that systems are synergistic. And behavioral health in the United States is a cultural system of its own. And finding ways that you can synergize your practice and the cultural context of your patient can lead to some pretty fantastic gains, both in your understanding and your connection to the patient and your ability to sell them the behavioral health care system. Next one, please. So here's one of the systems we set up, and though this is actually from one of the voodoo priests that taught me, and these are a variety of saint pictures and serums that he would use in his practice. Let me see if I have notes there, excuse me. Okay, so the experience of Haitians and Haitian Americans shows the very complex ways the traditional and indigenous ways of thinking can have on behavioral health. And why is this important? And it's just because there is a taboo surrounding Western behavioral health does not means that people are adverse to the idea of behavioral health. Sometimes it's just a matter of understanding how they conceptualize behavioral health. Understanding that gives license to promote the behavioral health system. Additionally, if you know the providers in your area, and if you've been practicing for a while, you may, and I'd encourage you to. Oftentimes, diaspora communities have individuals in the field that are members of those communities, and referring someone to someone of their own cultural background at times can make that transition much easier. So I would encourage you to do that and ask before you do. For example, if you have a colleague in behavioral health, or you refer to a colleague who's from the same cultural background, ask them if they'd like to be referred to an individual with their cultural background before you do it, because at times the assumption can be damaging. I know I've certainly gotten into that issue myself. Next slide, please. And this is just one of the little offerings we set up in our clinics. what we found is having, and this was in front of our clinic, we set up a little altar. This was an offering to a deity that I don't have a good understanding of. But I do know that this was important to the community to have this in our clinic. So we put it there. We gave them a big space to do offerings to this. And I do know that it's related in some way to health and wellness. And what we found in our practice is allowing the community to influence the physical built environment within our clinic help to sell behavioral health. And the important takeaway from that is the social environment that you're bringing into the clinic is just a piece of what the patient is seeing. They're also seeing a physical environment, and that's manifest not only in the built environment of the clinic, but also the things you put in the clinic and the way you and your colleagues move throughout it and your interaction with the environment. I would encourage you in your practice and in your leadership within your organization to shape your environment in a way that is meaningful to the community and is inclusive to all of the different perspectives and folks that you serve. You may not need to put an altar, but I would encourage you to find small ways to make people feel more welcome. So at that point, we will open things up to questions, concerns, or points of conversation. I will open that up. Anyone? And just pop a hand up, please, if you have something. Excellent. So thank you all very much for your time, for your sharing, and for your understanding. I took a lot personally from this session, and I appreciate the vignettes and the insider knowledge from your own clinical practice. It certainly added to my body of language knowledge. And I hope that you all were able to add to your body of knowledge as well. Thank you all, and have a good holiday.
Thank you.